Today, on the fourth session of lecture series organized by ECG Study Group, ECG Basic and Beyond. Today, we have amongst us one of the most eminent cardiologists, Professor Dr. Chowdhury H. Ahsan. So he's going to deliver his lecture on ECGs in ACS, ST segment elevation MI, Occluded Culprit MI, the triage transfer system. So before the starting of the lecture, I'd like to request our respected Professor Rafique sir to say something about Hafiz Ahsan sir, and then we proceed. Rafique sir.
Hello, good morning. Assalamu alaikum, everybody. Hafiz needs no introduction. He's well known. He's a professor of medicine and cardiology. But beyond that, the most important part about Hafiz is he's passionate about Bangladesh. We are both out of the country for a long, long time, but we haven't forgotten our homeland. And Hafiz keeps working. And anytime I have asked Hafiz to participate in any activity that benefits Bangladesh, he has always done so, even when he's extremely busy. And I'm very grateful and thank Hafiz for that. And without further delay, I would like Hafiz to start his lecture.
So thank you, everyone. So, Assalamu alaikum. It's a little late tonight, but আমি আজকে একটু বাংলা ইংলিশ মিলাই বলি, কারণ আমাদের সাথে বোধহয় কেউ ইংলিশ স্পিকিং পিওরলি or solely ইংলিশ স্পিকিং নাই। তো আমি একটা জিনিস বলি যে আজকের লেকচারের যে টাইটেল পেজ, যে রিভিজিটিং স্ট্র্যাটেজিস, STEMI criteria or occluded MI, culprit AMI, and I'll show you some data on the artificial intelligence. It is important why I'm doing this way, because everything in cardiology starts with the patient. And then the first thing we do, in addition to history and physical, we also do the EKG, and that means a lot or may not mean a lot. So why this EKG and calling the EKG? What's in a name? আমরা সবাই জানি যে শেক্সপিয়ারের বিখ্যাত কোটেশন যে রোজ রোজ যদি হয় তাতে নামে কি যায় আসে, বাট ইট ডাজ ম্যাটার, ইট ডাজ। সো আজকের লেকচারের গোল হবে হাউ উই ক্যান ফাইন্ড আউট EKGs in the context of a patient. It indicates acute coronary occlusion EKG, and basically we'll focus how we can find out those patients presenting with acute coronary occlusion, or those patients who are presenting with acute coronary with threatened vessel. Why I'm describing this way? Because these are the patients who are at risk of death. When it comes to death in medicine, not just in cardiology, anything that alters death, I think we need to pay attention. We are in the business in medicine to delay death. That means we improve survival, improve symptoms, give comfort to the patients, and do things to prevent further complications. So if you look at the data, historically, EKG, we pay too much attention on the Q waves and say whether this is a done deal and therefore nothing can be done. But we realize a significant number of patients with Q wave still have myocardium that can be salvaged. And in many patients, there is already transmural, maybe 1/3, half, and still Q wave not showing in the surface EKG. So it is very important that we shy away from the Q wave and Q wave guided strategies for treating these patients. And we have. What we have done, we have emphasized the recognition of ST elevation in the EKG. ST elevation is an EKG finding. And then in the correct clinical context, we call them MI, STEMI. And then we'll talk later in this program that there are patients where there may not be STEMI, but they have occluded vessel. Why I'm saying this? 56% of the individuals with acutely occluded coronary arteries may not show ST elevation. 25 to 33% of individuals classified as non-STEMI have actually acutely occluded coronaries. So this is very important. And 6% of the individuals classified as having very high risk non-STEMI actually get the angiogram in less than 2 hours. This is a very interesting finding that we fail to recognize occluded artery, and therefore we call them acute coronary syndrome, non-STEMI, and we say we'll treat medically or do invasive strategy. And when we did the angiogram, we found that they have culprit arteries. But if you think about this, less than 10% of those high-risk patients actually went for angiography. So these numbers are really of concern. So what we need to do, we need to have a vigilant system that how we can give more priorities to overall evaluation of the patients so we can deliver the care in a timely fashion. And if you look at this whole business of troponin have actually helped us and actually hurt us big time. Because whenever we talk about the type 1 MI, which is plaque rupture, plaque erosion, and plaque nodule, we need to understand those are the patients where acute invasive therapy can make a difference. The rest, type 2, type 3, we don't need to worry about because they die. The type 4 is the procedure related, and type 5 is cabbage. Type 1, we need to tease out that who presents with ST elevation MI, and then who have the underlying pathophysiologic mechanism to actually give platelet activation and the coagulation cascade activation to occlude the artery, risking the patient for death. This is 67-year-old, ST elevation, and then this is the EKG. So these patients, they are not really, are not challenging in terms of diagnosing. And it is important that we diagnose these patients because it doesn't take a genius to figure out that the longer we delay this diagnosis and then we hesitate to give the therapy, we may lose the patient. This is a high-grade stenosis, and that was with the slow flow. And then we did the invasive strategy. We restore flow, and then we get a good outcome. And I'm not talking about the optimal PCI plaque rupture. This is what I told you about. It is important to understand the pathophysiologic mechanism and then evaluate the patients. The imaging guided has much better outcome, but this talk is not on those. What we need to understand that other than just recognizing the EKG and triaging this patient, and then optimal PCI only can make a difference in terms of best outcome. This is another EKG. You can see there is inferior ST elevation. And this is how we have divided traditionally ST elevation, non-ST elevation, and then no troponin but rest angina or new onset angina, crescendo angina, calling it unstable angina. And then we understand that this has significant burden in the healthcare cost as well. And in the US, we are also trying to recognize this patient, triaging this patient, and delivering this care. And this is the evolution of the EKG. We all know this. We all read this in medical school. But the problem is that if we go by only EKG criteria that we have, then we also miss, as I showed you the data, for those patients who have very high risk features and may need therapy earlier. Also, we need to recognize there are other causes of ST elevation where it is really not STEMI, but we panic and we deliver the care too much, too soon, and cause adverse outcomes because of the nature of the therapy, such as anticoagulation, cath complications, when it is really a 29-year-old with ST elevation because of pericarditis. And we know this. This is no-brainer that there is plaque growth, plaque rupture, then disruption of the endothelium, plaque erosion, and sometimes the calcific nodule, small number, can be related to this. And this is what I told you earlier. The LVH can give ST elevation. Left bundle can give ST elevation. Acute pericarditis can give ST elevation. Then there may be pseudo-infarction pattern for hyperkalemia. So the clinical context is very important. If you look at this EKG panel from left to right, this is the fourth EKG. This is a patient with dialysis coming with this EKG and fatigue, and we are rushing to the cath lab. We may actually lose the patient because of the arrhythmias and death. Patients with acute anteroseptal infarct and distinct Q waves, then right bundle, still we can read ST elevation and look at the pattern, and we should not be fooled. And then patient 26-year-old who is flying from Bangkok to Los Angeles and had some dizziness and chest pain, went to the cath lab. Cath is normal because it turns out to be Brugada syndrome. So it is not just the EKG alone that we should look at. We should look at the patients. What the artificial intelligence is doing, that it is incorporating a lot of data. And I am calling the artificial intelligence not artificial. I think we should call artificial intelligence as our collective intelligence, because we are actually telling the machine that this is what we have learned so far from the literature, and the machine can be consistent to vomit out the synthesis of all the intelligence that we have injected into the machine. And now machine is saying, hey, this is the collective intelligence. And it can be high risk patient with an underlying occluded coronary. You need to go to the cath lab or stay away from it. It may be hyperkalemia. Don't do it without looking further. And we have given criteria. But look at these criteria. This is only a decimal point. But if the clinical context is right, then we don't need to stick to the criteria and deny someone a potential therapy. At the end of the day, it is the patient and the clinical context, and then you interpret. So early management is important. That's why we have this awareness about, this EKG transmission, point of care, EKG transmission, and then get the experts available when the point of care EKG is transmitted or the ambulance system transmits. And we can together do it. And we can do it so we can tell the local doctor that, hey, if it is ST elevation, clinical context is right, then give the thrombolytics, drip and ship the patient out. And this is something that we need to do a mass education that, yes, recognize this patient. Time is muscle. You will be able to salvage these patients from further damage and then salvage the myocardium and salvage the patient. This is pharmacoinvasive therapy, and we should have a system of care. We should give lytics, drip and ship, or if the cath lab is close by. Only last week, we have my cousin had a STEMI and in Dhaka city and was told to consult cardiology. There was no system of care. ওকে বলছে যে তুমি আপনি কার্ডিওলজির সাথে যোগাযোগ করেন। He doesn't know how to get this. At least we were able to transfer this patient to a primary PCI hospital, even in the capital city. It is mind-boggling to me that a treatment cannot be given because there is no established system of care. And of course, if there is a lytics given and the lytics fails, then we should recognize again by the patient and by the EKG. Repeat EKG, still ST segment not resolved and patient is having chest pain, then we should rescue PCI. But whatever we do, if we put this in early hours, then absolutely we can make a big difference. Historically, we started with the primary PCI, then stent, then pharmacotherapy in combination. And you can see that lytics and primary PCI, there is a difference. But if you look at the pharmacoinvasive lytics and the primary PCI, it is neck and neck if there is a system of care. So we need to recognize by ECG that who has occluded MI, and not only the EKG alone, we need to look at the anatomic classification and then figure out how we can triage these patients. So we need to shy away. I told you about the statistics about the STEMI features only versus other features. And therefore, when they did the artificial intelligence, this is the data. If you look at the EKG model and you deliver the care with the EKG model, the sensitivity and specificity detected by the artificial intelligence, what I call collective intelligence, they perform better than bona fide cardiologist interpreting the EKG and making decision in terms of how to triage this patient. So it is very important that we understand this, that we can recognize the traditional ST elevation MI and also other features that can indicate acute coronary occlusion, so we can give the reperfusion therapy. This is very, very important as I'm trying to explain. Any questions so far, please raise your hand or stop me. I'll be happy to answer. So if you look at this, what they have done in the collective intelligence, they have injected all the findings from all the trials. This is no brainer, right? This is a patient has LVH, clinical context does not match. So the artificial intelligence says, look at this patient LV function normal. And then there is LVH, there is an alternative. Even if you go to the cath lab, you're not going to find. And they did not find, it was normal EKG. So this is very important that we need to get this sorted out by a collective interpretation, what we know from before. And I give you this, that it is not only to recognize the chances of occluded MI by STEMI criteria, but look at the posterior MI, how often we can miss. Isolated posterior is something called the non-STEMI, and we miss it. And this is the South African flag sign. And you can look at this, that there is lead 1 AVL. Sometimes our eye misses it. And look at the lead 2, 3. This is somebody who interpreted this reminding us of South African flag, but it indicates that there is a significant coronary occlusion. This is another Aslanger pattern in the EKG. One lead in lead 3, because it does not fulfill the criteria, you may not call it STEMI, but this is an EKG, which is really important, because if you look at this EKG only lead 3, but there is V6, V5 ST depression, this can be a multi-vessel with a culprit lesion in the RCA or dominant left circumflex. This is the Aslanger pattern. So these are the collective wisdom that we are injecting into the EKG, and they are asking few clinical features, and they're telling us, and it is not just replacing the cardiologist. It is not. It is not going to replace the cardiologist, but it is giving you some more insight, helping us how we can identify these high-risk patients who really need urgent intervention in terms of triage and starting the treatment, and then we can transfer or do the invasive strategy as needed, depending on where these patients present in terms of point of care centers, remote centers, non-PCI centers, but not understanding that we are in trouble is not an option. What we do is different, but at least let us understand that this is a high-risk patient and needs to be taken care of.
So
And this
so can I ask you a question?
yeah, sure.
From trainee perspective or from a junior doctor's perspective, those who are listening to this, if a patient comes with the ECG of Aslanger pattern or
Yeah,
only inhibition in one lead with
Yeah.
symptom that may not be totally fulfilling the criteria of acute coronary syndrome, so how that patient should be dealt in the emergency setup?
okay. So, okay, let me, তোমাকে আমি প্রথমেই বলি, if the clinical symptoms is not convincing, that raises question. But the clinical symptoms is convincing, say the 10 out of 10 chest pain, diaphoresis, and still holding blood pressure or blood pressure already low, then you know something major going on. So then you divide them into hemodynamically stable acute CS, acute coronary syndrome, or acute coronary syndrome with shock. But if the symptoms is iffy, then you can do more evaluation. But if you ask me, which you did not, that is that alone a criteria for lytics? I don't think that we are there yet. But we should recognize this is cardiac and high risk cardiac. At least we start the therapy, whatever way. And if we have a primary PCI center, the patient is already in, then we should start taking this patient for invasive strategy. We should not delay.
Okay. Now I ask question to Rafique Ahmed sir. Sir, would you send the patient to cath lab with this ACG, a hemodynamical stable? Would you like to send the patient to cath lab for assessment of coronary?
Well, the problem is in the United States, it's pretty aggressive. I remember one time I went to a meeting and everybody is talking about many strategies. Here, we are pretty liberal, right, Hafiz?
Yes. So let me tell you, Rafique, by this, exactly the same thing. In American Heart, ACC, ESC, they call it guidelines. In World Heart Federation, we are going to tell it as roadmap. The roadmap for therapy, the reason is the local resources, local expertise, and financial, all these will come into play. But to answer your question, Tushar, what is ideal and what is practical, we always will fight with that problem. But in that case, if you do not have any explanation and the patient is doing badly, then you should recognize and don't stick to, oh, it does not have two contiguous lead. No, you don't need to, because the lead 3 only, but the patient is doing bad, and you have now get more collective experience, because somewhere in the world, many people looked into these EKGs with ST depression and then realized that this is actually multivessel with a culprit as well. We need to accept that. That's what I'm saying. And this is a 71-year-old What do you think about this EKG? This patient has, say, chest pain and ischemic sounded chest pain. What do you do? So this doesn't have the ST elevation, but the patient has significant MR and ischemic MR. And then this, the cath lab, we did take to the cath lab, and you see there is a high grade right coronary, and it is a threatened vessel. It is still a STEMI 3 flow, but that may not last if you don't do early intervention. So these are the messages that we need to, then you do primary PCI, and even in primary PCI, you can do imaging and get optimal. So next, I'm going to show you a series of EKGs. I call it STEMI and STEMI mimics. One thing we need to understand, ST elevation does not mean MI. MI is clinical. The ST elevation is EKG finding. We need to put that in the context of the patient. And then we call it acute ST elevation MI. Without that, we'll be fooled. And this is exactly what artificial intelligence will do, or I call it collective intelligence, not artificial, because artificial intelligence is not artificial. It's actually real. We are telling the machine how to interpret. So this is extensive anterior with anterolateral changes. There should not be any doubt, because not only the clinical context is important, the EKG is extensively indicative of MI, and it does fit, right? And there is no prohibitive. The same EKG, what you do is different. If this is a 93-year-old grandma coming from nursing home who has DNR, then no, you don't need to take to the cath lab. You need to negotiate and give comfort care. So not only recognizing the EKG pattern is important, clinical context is important. What you do also depends on the clinical context. We had similar EKG, I forgot to upload, in a patient who had acute myeloid leukemia, platelets 10,000. We can't do anything in terms of invasive strategy because it will be harmful. This is another patient with EKG changes. What should we do with this patient? Patient is 50-year-old, diabetic, hypertensive, and with this EKG, what should we do? Any offer? Tushar, because I don't know much anybody, so I can ask you.
So what is the anything else? Clinical context.
Next, yeah, everybody that I'm presenting is 50-year-old, male, diabetes, hypertension, hyperlipidemia. And no prior MI, no other significant comorbidities, no allergies, contrast, no problem, kidney function good. What do you do?
The ST elevation pattern in all leads, global ST segment elevation pattern with PR segment is depression in inferior leads and elevation navier, that goes in favor of pericarditis.
Acute pericarditis, and no need to panic. Think about this. If the point of care physician is over enthusiastic and giving lytics, that is harmful, really harmful. But the point of care physician is savvy enough to involve you, expert, then we can give and we can empower the physician to be comfortable that say it is acute pericarditis. If we have a point of care ultrasound, LV may be hyperdynamic. So that way we can help. I see somebody raised hand. Can you open the microphone for everyone so we can hear?
Rafique, can I ask a question?
Yeah, Rafique bhai.
So let's be devil's advocate. So let's say the LED occluded, at the same time, RC occluded.
Yes.
Question would be, the patient will be really sick.
Yes.
I mean, it is very, very unlikely that this will happen, but let's assume it happened.
Yeah, আমি আমার ফেলোদেরকে বলি যে God is not that unkind to give you coronary occlusion in all three major epicardial vessels. But I don't know why I'm invoking God. But for argument's sake, Rafique bhai, you are absolutely right. And I think the audience should pay attention. Rafique bhai's question is very important. But also Rafique bhai said the patient will be very sick, probably hypotensive. And when there is hypotensive, in a patient like this, you definitely need to look at chest x-ray, if possible, point of care ultrasound. And yes, you can also use your stethoscope. You may see if there is a significant pericardial effusion already, muffled heart sound. But these are the things that you need to realize. And also, it is perfectly fine that the point of care physician involves us, the experts in that situation.
There was a case actually recently came from Bangladesh and had similar ECG, and the physician did cath. So it's actually not unreasonable if you are in a center where you can say, well, I just want to make sure, but make sure that you don't give heparin. So if you can do a cath without heparin, just to make sure, it's okay. But I think what Hafiz emphasized is not to give thrombolytics, not to give heparin. That's crucial.
And this is very important. Let me tell you another important thing. This is not the EKG of the patient we are talking about, but similar. Take my word, it is a similar case. A 29-year-old female who gave childbirth about 6 weeks ago or 4 weeks ago, and then had anterior ST segment elevation. And will you give thrombolytics in that patient? The patient is in a center, in a point of care center that is little remote. And the nearest cath lab is about an hour away. Will you give lytics?
Yeah, anyway, this is an important ECG, an important case, Hafiz.
Yeah.
So we
And
need to.
I would not give lytics because you need to think. I told you the pathophysiologic mechanism. 29-year-old female, recent childbirth, it can be spontaneous coronary dissection. So if you give lytics, you'll be really doing harm. And imagine if this patient gets lytics, an intracranial bleed, which can be substantial and well known in the literature, and that will be really sad. So why this is going to happen? Because we did not take in totality. You can defend yourself that I saw this in Bangladesh, young patients also get this, so that but the question is, use the experts, get somebody to back you up, and then see what our collective knowledge and experience will say. So this is the message I'm trying to give. Yeah.
The question is that if somebody decides to cath that person, will that be unreasonable?
No. It's spontaneous coronary dissection. If that is, I'm trying to say, if particularly you have the resources, which is an hour away, you cath, but majority of the time, Rafique bhai, you don't need to do anything. When you recognize the spontaneous coronary dissection, hands off. Just preside over this. I have coronary dissection, but I'm not going to mention this, who actually had VT-VF, and I put impella and support and did not do anything, brought back to the cath lab, and I proved that the patient has good established healing and good flow.
But I think both of the cases, the case before pericarditis and this case, is so important that what not to do.
Yes, what not to do. Yeah.
What not to do.
And then this is the patient, the left bundle, and the patient comes in with some fatigue, malaise, and non-specific, and you see the left bundle. Then you panic, and then you say, what should I do, right? Particularly this, yeah.
Your previous case, what is your current practice now? That is, are you taking the using the artificial intelligence for decision in such cases routinely?
No.
Practice in USA.
Okay, so we are trying to put in the context, because actually the published paper, and I don't know, you know that we are actually presenting in Spain, Madrid, our experiment with point of care center. I have this Sure Care Foundation, Rafique Bhai is part of it. And we are getting these EKGs from remote areas. And we did a paper and that got accepted. And we did not have artificial intelligence. We had our collective intelligence. And now the companies have made this as a software. We are reaching out to the software. And of course, these softwares are expensive, but we are going to see whether we can collaborate. In my center, it is not artificial intelligence yet, but I'm just making you aware that this is available now. Hopefully, the societies will come up with some plan that can we make it cheaper, available, and all that. But until then, and even when we get that, it is important that we have experts also behind this. We cannot let it go alone, you know. So this is another one is the lab bundle. And the lab bundle, you need to have all lab bundle, and this is same, we are good. If not, then it is important to recognize the EKG pattern. And also you can use the Garbosa criteria, the discordance, ST segment, a precordial lead, S wave deep, ST going up, discordant, more than 5, then concordance, and then ST depression. 3 criteria will make your sensitivity less, but your specificity will be high, but in the current clinical context. How about this one? Same patient history. What will you do? This is a tough one, right? Will you take this patient to the cath lab, or what will you do? Chest pain. And the chest pain getting worse. So,
Sorry. Before going to the discussion, the problem with that LVBB patient, if the patient
Yeah.
is middle-aged or elderly and having chest discomfort, not typical chest pain.
correct.
Many a times the problem happens in the centers where there is high sensitive troponin available and has to send the test.
Yeah.
That high sensitive troponin I level many a times comes at a reasonable higher level.
Yes.
And that creates a problem.
Yes, yes,
That's
absolutely.
the-
So let me তোমার এই কথাটাকে একটু ভেঙে ভেঙে আমি বলি যে যদি আমাদের পয়েন্ট অফ কেয়ার আল্ট্রাসাউন্ড থাকে আর যদি তুমি দেখো যে লেব বান্ডল এবং বাগেরহাটে আমাদের এরকম রোগী ছিল, আমাকে পাঠাইছে এলভি ফাংশন ইজ সিভিয়ারলি ডিক্রিজড, ডাইলেটেড। আমি তোমাকে আলোচনার জন্য বললাম 50-year-old, ধরো সেটা যদি 35-year-old হয় রোগী, আর যদি লেব বান্ডেল এবং সিভিয়ার এলভি ফাংশন, ইভেন 50-year-old, লেব বান্ডেল যদি সিভিয়ার এলভি ডিসফাংশন হয়, ডাইলেটেড গ্লোবাল, what is the statistical probability that this patient has acute coronary syndrome with LAD occlusion, for example?
Less than 1%. Sir, I'm Dr. Ajay from Sylhet.
Absolutely, totally
Less
agree
than
ভাই,
1%.
তোমার
Yeah.
সাথে টোটালি এগ্রি করি।
Less than
এবং
1%. Yeah.
এক্স্যাক্টলি সেই রোগীকে আমরা ট্রোপোনিন পজিটিভ আসলো, বিএনপি হাই আসলো, রোগী অ্যাফোর্ড করতে পারবে না, চায়ও না। আমরা ওই গাইড 4 pillars অফ হার্ট ফেলিওর থেরাপি দিলাম, 3-4 মাস পরে এলভি ফাংশন কেম ব্যাক 45%। And then the question is, আমি আমার এখানকার কলিগদের জিজ্ঞাসা করলাম যে তা এখন কি ক্যাথ করবা? অধিকাংশ, yeah, absolutely, we should do cath. I said, no, if the patient is doing good, then I'm doing good. Why I care? But Tushar, absolutely brilliant points. Another example, আমরা যদি ওই MI6 এর মতো বা স্কটল্যান্ড ইয়ার্ডের মতো অনুসন্ধানী মন নিয়ে আলোচনা করি, যে এই রোগী মনে কর তার প্রিভিয়াস ক্যাবেজ আছে, 70-year-old, তার এই ধরনের একটা লেব বান্ডল, মোস্ট লাইকলি হি ইজ নট প্রেজেন্টিং উইথ অ্যাকিউট করোনারি সিনড্রোম স্টেমি, তার প্রিভিয়াস ইকেজি খুঁজতে হবে। বাট টেক এ ডিপ ব্রেথ, আমরা বলতে পারি রোগীকে যে আমরা শিওর না একটা হার্ট অ্যাটাক হচ্ছে, কিন্তু নেক্সট স্টেপ কি হবে এটা আমরা ঠিক করি, ঠিক আছে? এটা, বাট ডোন্ট গিভ লিটিক্স বিকজ it can be a high grade graft, or it may be ruled in non-STEMI that may need cath, but we don't need to rush.
স্যার
Okay.
But yeah,
স্যার আবার একটু আপনাকে ইন্টারাপ্ট করি। আপনি বললেন যে পেশেন্ট সিভিয়ার এলভি ডিসফাংশন ছিল, এলভিবি ছিল, with 4 pillars the patient ejection fraction got improved, and the person cardiologist they want to do cath, and you are saying that no need of cath. But what if the patient has underlying obstructive coronary disease,
so
which
so
needs
so যেহেতু তুমি জিজ্ঞাসা করলা, কারণ আমি দেখি যেটা রফিক ভাই আগেই বললেন যে যে প্র্যাকটিক্যালিটি অ্যান্ড আইডিয়ালিজম। তুমি যদি গাইডলাইন্স ধরো, এলভি ডিসফাংশন more than 40-year-old, then you should exclude coronary disease. But in that case, patient LV function better হয়েছে, গাইডলাইন্স ডিরেক্টেড থেরাপি দিয়ে এলভি ফাংশন আরো ভালো হয়েছে, এখন তুমি চিন্তা করতেছো করোনারি ডিজিজ লেস লাইকলি। বাট যদি তাহলে চিপেস্ট ওয়েতে কি করা যায়, যদি পেশেন্টের রিস্ক ফ্যাক্টর থাকে, তারপরে যদি 50-এর উপরে হয়, আর যদি তুমি অ্যানজিওগ্রাম করো 20,000 টাকা দিয়ে, most likely you will get normal. You can tell this to the patient. I'm not going to prevent you doing cath, but do you think that this patient has significant ischemic cardiomyopathy leading to LV dysfunction that got better without fixing the coronary with 4 pillars of heart failure therapy? It is unlikely.
স্যার আমি একটু যোগ করতে চাই স্যার। আচ্ছা স্যার, আচ্ছা ও স্যার সরি স্যার, স্যার এই ধরনের পেশেন্ট আমি প্রায় পাই যে এলভিবি পেশেন্ট ডাইলেটেড কার্ডিওমিওপ্যাথি, এবং আমি কিন্তু যেহেতু পেশেন্টের ক্রনিক প্রবলেম থাকে অর্থাৎ ফ্যাটিক, শর্টনেস অফ ব্রেথ, আমি স্যার সিটি করি, এবং মোস্ট অফ দ্য পেশেন্ট সিটি ইজ অ্যাবসলিউটলি ক্লিন, নাইস, নো ক্যালসিয়াম স্কোর জিরো, সো সিটি ক্যান হেল্প টু ডিফারেন্সিয়েট NICM to ICM.
Absolutely brilliant. তুমি যা বলতেছো আমার কানে মনে হচ্ছে যে মধুর সঙ্গীতের মতো, কারণ it is like it's music to my ears. This is the practicality. তুমি তো সিটি এনজিও করো, আমি তোমাকে বলবো just do calcium score, because if the calcium score is 0, we cannot, ideally people will talk about, oh, there will be non-calcified high grade plaque, but we cannot be perfect. Even calcium score cheaper, you can just do that depending on the practicality. So we need to be creative. We cannot respond to the guidelines formulated by people who have all the resources and do not have any sense of practicality or understanding how resource poor we can be. And we need to deliver the therapy. And think about this. That patient was able to afford the neprilysin inhibitor, the aldosterone receptor antagonism, and আমাদের pharmaceutical কোম্পানিগুলোর দাম আমি জানি যে বেশি, কিন্তু অ্যাটলিস্ট অ্যাফোর্ডেবল, এবং সেটা আমরা দিতে পারছি ওই রিমোট এরিয়াতে। আই থিঙ্ক দ্যাট ইজ অ্যান অ্যাচিভমেন্ট। সো
আমি আচ্ছা
হ্যাঁ বলেন।
তার আরেকটা বিষয় যেটা আমরা আগে জেনে আসতাম যে নিউঅনসেট এলভিবি is another criteria for the reperfusion. But how much you agree with this statement?
It's a clinical context. It's the clinical context. If you have a left bundle in front of you, and patient is having chest pain, diaphoresis, LV, and the patient is crashing, burning, and you have an echo showing whole anterior wall down, it doesn't need a break. It's raining, you go out, you get wet. It is as simple as that. But if you can afford to wait and recuperate, depending on the practicality, আমি তোমাকে বলি যে তোমার যদি ওখানে ভিআইপি হয়, তারা এখনই হেলিকপ্টারে করে ফ্লাই করতে পারে, I think it's okay to let them fly. So I'm very flexible. But we need to...
আহসান ভাই, ওই ইউএসএর এলপিপির একটা গল্প বলি। একজন নামকরা প্রফেসর সাহেব হজে যাবেন, ওই দিন সকালবেলা হঠাৎ একটু ডিসকমফোর্ট হয়েছে, ইমার্জেন্সিতে আসছেন, তার এলপিপি, তারা বলছেন ইউএসএর এলপিপি এখনই থ্রম্বোলাইসিস করবে। আমি ফোন শুনে বললাম যে ওনাকে এক্ষুনি আগে এতে নিয়ে ইকোটা দেখো, এটা আমার কাছে মনে হচ্ছে না। ইকো করলো, then they do the echo and it found that there is no actual valvulation abnormality.
Yes.
He was actually having on and off LPBP.
Yes. So this is very important.
Wait,
To be a
can I
clinician.
just,
Yeah.
can I
Rafique
just
bhai.
say something? Can you go back to that ECG?
Yeah.
Okay. So this patient, two things. One, let's assume that there was coronary disease. If the coronary disease was causing, this is not for Hafiz and the panel, this is for the general people who are listening, that ejection fraction improved. Even if this patient has coronary disease, it's actually non-ischemic cardiomyopathy.
Yes.
If the coronary disease caused the cardiomyopathy, it would not have improved. So the second question is that we also need to practice socially appropriate medicine. Once you tell a patient, however poor they are, that, oh, look, you need a cab, they will try to find money and borrow it. So we also have some degree of social responsibility based on our past clinical experience. Look, you are doing fine. This is what is the likelihood. Of course, there is a possibility that 1 in 1,000 patients may have significant disease. We may miss it, but we have saved money for 999. Hafiz, do you agree with that comment?
Absolutely, Rafique bhai, I wanted to take this opportunity to pay respect to my teacher, and you all know Professor S.G.M. Chowdhury, and he was giving a lecture, and he said that if you know the prognosis is bad and the cancer is advanced, and you still giving lecture on therapy and it is futile, he was talking about futility of care. আমি সারা জীবন মনে রাখি যে not only you are doing harm to the patient, you are bringing the whole family to the street, and this is criminal. ওনার কথাটা আমার কানে এখনো লেগে আছে যে ইট ইজ ক্রিমিনাল অফেন্স যে তুমি একটা ফ্যামিলিকে রাস্তায় নামাই দিলা। I think we should not do that. We need to be very practical and be reasonable and engage in the dialogue. Ask another person. We are here to be with you. So don't take the responsibility on your own. Share your things. আমি মাঝে মাঝে ফিল করি রোহিত ভাই, there should be a national online services for STEMI care, and I'm going to be the first person to volunteer. তো কেউ একজন আপনার ব্যাকগ্রাউন্ডে নয়েজ হচ্ছে।
ডাক্তার প্লিজ নয়েজ করো। ডাক্তার প্লিজ।
So এটা আমি যদি বলি যে ক্লিনিক্যাল কনটেক্সট, a dialysis patient came to the emergency room with fatigue and chest pain. What you will do?
Antibiotic খাইলে খাওয়ার উচিত হবে যায় ভালো।
হোস্ট প্লিজ আক্তারুজ্জামান, মোহাম্মদ আক্তারুজ্জামান, তাকে সাইলেন্ট করুন।
তো তাহলে কি হবে? এটা হচ্ছে হাইপারক্যালেমিয়া, রাইট? ইটস অ্যাবসলিউটলি ইম্পর্টেন্ট টু রিকগনাইজ দিস। এবং যদি হাইপারক্যালেমিয়া আমরা রিকগনাইজ না করি, we can be in big trouble. And look at this ST segment elevation in lead AVR. It is a shoulder down ST elevation. Almost certain that these are not usually the STEMI. And the clinical context is important. And what about this one? This patient came in, you can say that's inferior, but look at the precordial leads. There is ST segment depression and then T upright. It is inferior posterior MI. What about this one? This patient has a history of cocaine abuse and chest pain. This is a classic sign of LVH and LVH related ST elevation, right? LVH related. A point of care ultrasound can be really helpful, but you can see an LVH Sokolow-Lyon criteria, তারপরে Romhild Estes criteria, Cornell criteria. But let me tell you, in a 12 lead EKG, আগে তো আমরা একটা স্ট্রিপ করতাম EKG 12 lead, এখন আমরা 12 lead এইভাবে করি। দেখছেন যে V2 V3 fusion, যে S1 of V2 and R of V3, এটা fusion. আমার ফেলোরা এটাকে বলে আসান সাইন। এই আসান সাইন means this is LVH until proven otherwise. So this is LVH related. And what is this one? এটা কাউকে না কাউকে বলতে হবে। পেশেন্ট চেস্ট পেইন, 10 out of 10 চেস্ট পেইন, এবং ক্যাথ ল্যাব রেডি, এবং এটা পার্টি কথা বলতেছে তারা ক্যাথ ল্যাবে যাবে কিনা। আপনি কি বলবেন, এটা কি স্টেমি আর নন স্টেমি?
STEMI posterior isolated.
Yes, excellent, excellent. So this one patient is actually a real patient. A previous cabbage patient came into Las Vegas. তার একটা ডিজি স্পেল হয়েছে, কিন্তু ডটার তার বাপের সাথে থাকে না, কিন্তু ডটারের নিজস্ব সংসার আছে। কিন্তু এখন যেহেতু বাপের সঙ্গে, ডটার ভেরি সিম্প্যাথেটিক, ও বাবা বাবা এক্ষুনি হাসপাতালে যেতে হবে। ইয়ারে আসার পরে ইয়ার এসটি এলিভেশন এমআই বলে অ্যাক্টিভেট করছে। আমি গেলাম, পেশেন্ট বলল না বাবা আমার কোনো বুকে ব্যথা এখন নাই। আপনি কি করবেন?
অ্যানিউরিজম কিনা দেখা দরকার, ওল্ড এমআই।
And but what is their explanation for the ST elevation? Previous cabbage.
Posterior.
Huh?
ভেন্টিকুলার অ্যানিউরিজম কিনা।
Ventricular aneurysm, absolutely. And the patient is from Philadelphia, Pittsburgh. আমি বললাম রোগীর আপনার ডাক্তারের নাম কি? Happens to be my previous colleague. I called Oscar Marroquin. I said, hey, do you remember this patient? I said, yeah. I said, the patient is here. I said, oh, they has ventricular aneurysm. I said, yes. So what about this one? This is Rafique Bhai's case, paced rhythm and chest pain, but ST elevation, and they are worried about STEMI. Will you take to the cath lab just to have a look? Absolutely not. You look at the patient. Look at the patient, do a point of care ultrasound, and decide, because it is not interpretable by this, right?
Garbosa.
Okay. Some people invoke Garbosa even in paced rhythm. I'm not sure ER does it, but I'm not sure how valid that is. This patient is chest pain, pain getting worse. Patient has history of left bundle. Will you take to the cath lab?
Yes.
Absolutely. Yes, because it has Garbosa, all three criteria fulfilled. And patient is having pain. And look at the V5, V6. Okay. So
Actually, shape is more than important than size, I think.
Yes, yes. And also go by the point of care and the patient right in front of you. Okay. And what you can afford. Right bundle. Is the patient is having STEMI? The ER called this patient. First of all, this EKG does not have any ST elevation. So take that fear away. I call this, call a tiger, a fish, a fish. Fish দেখে টাইগার হয়ে লাভ নাই, আর ফিশ দেখলে ফিশকে ফিশ বলাই ভালো। এখানে ST এলিভেশনই নাই, রাইট? এবং এটা হচ্ছে এক্সট্রিম এক্সাম্পল অফ হাইপারক্যালেমিয়া। There is a very intimidating ECG, very massive ST segment changes, but it is actually hyperkalemia. And what is this one?
Brugada.
Brugada. So there are different types, and if you know the pattern, then it's okay to. And then they talk about pulmonary embolism. Extremely rare ST elevation in pulmonary embolism. But if it is, it has to be massive. So look at the vitals. Severe hypoxia. You have pulse oximeter, you have blood pressure, you have the clinical exam, and you can do point of care and look at the RV strain and look at the clinical context. This patient actually, this is my patient from a rehabilitation center and a neurosurgery 4 weeks ago, and had a PEA arrest. Pulmonary embolism does not give VFib. It is a PEA arrest. And this is De Winter sign, acute ST segment elevation. And it is usually LAD. And this is similarly in another patient with De Winter's proximal LAD. Look at this EKG. The De Winters, and then De Winters with proximal LAD, different kinds of pattern you can see, and it is reported in the article on the right side that you need to recognize this. Wallen's syndrome. This is another problem. Wallen's in the right clinical context, prox LAD, ostial LAD, but it can be a benign Wallen's with asymptomatic patient, LVH, and apical cardiomyopathy. All these can be variable. So you need to remember this can be a significant issue in the right clinical context. But if the patient is seeing as an outpatient, came in from home and no chest pain, do not panic. And I will finish with this EKG, 76-year-old in neurosurgical ICU unit, and then this EKG, and then troponin is positive. They are asking what to do next. Any input?
It's a cerebral T, I think.
Yeah, cerebral T, and then you do any echo, you may even see Takasubo. And usually these are long QT, and you don't need to do anything. And even if you do think that this is MI, look at the clinical context. There is intracranial hemorrhage. Don't panic. You cannot do much. Don't take to the cath lab. Cath lab is not a photography lab. However, there is a similar patient. My colleague told me, I said, do not do this. They did not listen. They've twisted his arms. He took to the cath lab. Coronary is okay. And then there is a echo done later. It's apical ballooning, Takasubo. Rafique Bhai has said a very important one. I want to highlight that. In a Takasubo patient, you may have a third diagonal disease. That doesn't explain the EKG. And there is TIMI3 flow. If that does not explain, then don't go after that. Another important said, Rafique Bhai said, if you have a LV left bundle and severe LV dysfunction, LV got better, like amader patient. Rafique Bhai je commenta korlen, the cath eventually kolla, kore dekla je the second obtuse marginal has 70% stenosis. That is not related to this cardiomyopathy.
Incidental.
So you need to realize what is CAD related cardiomyopathy, what is non-ischemic cardiomyopathy, and what is a mixed pattern. Sometimes we see that in alcoholic and other coronary risk factors, some may be mixed. If you want to know more about that, you may need further tools such as cardiac MRI, etc. But you don't need that. Vast majority of the patients, you can manage it if you have common sense and all the collective knowledge and experience. I will stop there.
Okay. Thank you, sir, for your nice and explanatory ECGs and the demographics have shown. And more importantly, how to proceed in a center where all the facilities are not available. So I'd like to request Professor Abdul Chowdhury, sir, to share his experience about this ECG and ECG, MI and MI mimics, and how we approach the patient in our setup. Wadud, sir.
The first thing perhaps is to listen. We do not listen to the patient, do not evaluate their chest pain or other symptoms. And that actually is the crunch point where you can identify whether the patient actually needs a ACS related approach or there may be something else. I think Tushar, that will be the most important thing. The second thing is ECG. And whenever you are analyzing an ECG, you do it systematically and corroborate with the presenting symptoms. And then, if you are in doubt, why don't you ask for help? We sometimes take help from juniors. It doesn't matter that you are a very experienced senior professor, still you may be in doubt. That's the point. Patient should be supreme in our thought to whether the patient needs intervention or not. And if he needs intervention, if the facilities are there, we should go for intervention. And if he is not, then we should think pharmacoinvasive approach. Even if that is not possible, then we should only rely on thrombolytics.
Thank you, sir. And now,
So
sir, আমি আপনার স্যার
Wadud, তোমার লেকচারে 100 ক্রস করছিল, আমার লেকচারে ট্রানজিয়েন্টলি অ্যাবাভ 50।
Definitely না, আসলে 50-এর উপরে ছিল, কিন্তু আরো অনেকে পরে দেখবে।
স্যার আমি আতার স্যারের কাছে
আমি তো রফিক স্যারকে প্রশ্ন করতে যাচ্ছিলাম। আচ্ছা
বলো, আমি একটু একটা জিনিস, if you have noticed something that Hafiz talked about artificial intelligence, but he also talked about collective intelligence. It is so important. Today in Bangladesh, technology is so good, you can reach anybody. The collective intelligence should not only be used during conferences, it should be used every day. Hafiz called his friend in Pittsburgh. He didn't have to, but he did. I think that's what is something we need to practice more in Bangladesh, that communicate with each other. Without there is this sense that, oh, if I ask somebody, maybe there is a sense that I don't know. It is, I always say, I'd rather be stupid than a scholar for the sake of my patient. I think that's something that it is, I see encouraging sign in Bangladesh, and I request everybody to reach each other and communicate. And the other thing that for the junior doctors, my Japanese professor told me that call the guy who is very difficult to call and who will shout at you, because that's the guy that's going to give you something good opinion. So don't be ashamed, shy to call somebody who is difficult to reach, because if you talk to that person, you will learn something new. Thank you.
Thank you, sir. It's almost 10:45 now in Dhaka. So I'd like to request Professor
তুষার,
Atahar
আমি
Ali.
কি রফিক স্যারকে একটা প্রশ্ন করতে পারি?
Sir, one question, only one question,
আচ্ছা
please.
আচ্ছা স্যার, আমি এটা আমরা যে বিষয়টা বেসিক্যালি যে হুইচ পেশেন্ট উইল গো টু ক্যাথ ল্যাব, এটা হচ্ছে মূল মেইন পারপাস অফ দিস লেকচার। সো ফার আই আন্ডারস্ট্যান্ড, I mean, only occlusive MI to differentiate from non-occlusive MI. So many of the case, around 30%, we are unable to detect STEMI equivalent. স্যার আমার প্রশ্ন হচ্ছে যে এটা কি আমরা STEMI ST ভেক্টর এবং ইলেকট্রোডের অ্যালাইনমেন্টের জন্য কি আমরা ST ইলিউশন পাই না, নাকি স্মল এরিয়া অফ মাসের জন্য আমরা সাফিসিয়েন্ট কারেন্ট থাকে না, যে কারণে আমরা ST ইলিউশন পাই না? Why electrodes fail to detect ST elevation in transmural MI, I mean so-called occlusive MI? It was.
Well, ECG is not, it's a crude modality. We use ECG, it's a very crude modality of identifying, and it has to be a big area. And a lot of it is also mathematical extrapolation. So I think what Hafiz tried to emphasize is the clinical scenario of the patient. That's the most crucial part. And putting it together. And then, of course, look for minor changes here and there. I'm sure if we had 64-pole EKG, which is impractical, we will see more changes. But that's almost impractical.
Very well said, Rafique bhai. And the other thing is that the thickness of the myocardium, because it's a wavefront phenomena, the way the infarct happens. So if you are in the early hours and you can see the EKG evolving, you may not see the full features. And that is our job to identify the patients at early hours. And আমার এই টক কিন্তু এটা না যে কে ক্যাথ ল্যাবে যাবে আর কে ক্যাথ ল্যাবে যাবে না। আমার এই টক আমি ফোকাস করতে চেষ্টা করেছি যে who is at high risk and at least how we can diagnose. তারপরে যদি ক্যাথ ল্যাবে যদি না থাকে, there are other resources. কিন্তু বিনা চিকিৎসায়, বিনা রোগ নির্ণয়ে রোগী মারা যাবে, এটা আসলে অ্যাকসেপ্টেবল না।
This is the problem, Hafiz bhai, because we have seen patient where there was initially hyperacute phase, but then the concerned doctor failed to recognize it. And when the patient later came on with heart failure, then we find out that already the acute has set in. And this is very, very sad. We sometimes find this type of patients.
আচ্ছা, যেটা LCX territory, maximum time we miss to diagnose LCX territory.
And imagine it's recognized. The LCX is the silent artery, electrically silent. But if the patient is clinically overt, then why you are not taking care of it?
And thank you, sir. আমি আতার স্যারকে অনুরোধ করব তার কনক্লুডিং রিমার্ক দিয়ে আমরা পরবর্তী প্রোগ্রামের কথাটা বলবো। আতার আলী স্যার।
আমি শুরুতেই হাফিজ ভাইকে থ্যাঙ্কস জানাচ্ছি এই জন্য যে আজকের রিয়েলি এটা খুবই আউটস্ট্যান্ডিং লেকচার ছিল। আমি পার্সোনালি রিয়েলি মানে খুবই বেনিফিটেড হয়েছি, কারণ আর্টিফিশিয়াল ইন্টেলিজেন্স, কালেকটিভ ইন্টেলিজেন্স, অক্লুডেড এমআই, অনেকগুলো নতুন নতুন টার্ম আমার কাছে খুবই প্র্যাকটিক্যাল। আমি পার্সোনালি খুবই বেনিফিটেড, এবং আমার মনে হয় যে আমাদের ইউজুয়াল টার্গেটের চাইতে আজকে পার্টিসিপেন্ট কম হওয়ার কারণ আছে কতগুলো। তবে যারা আজকে লেকচারটা শুনে নাই তারা অনেক কিছু মিস করলো। এটা রিয়েলি একটা আউটস্ট্যান্ডিং লেকচার ছিল, এবং আমি হাফিজ ভাইকে রিকোয়েস্ট করবো যে এই যেহেতু বেসিক লেকচারে কতগুলো টার্মিনোলজি শুধু আমাদের জন্য না, আমাদের যারা স্টুডেন্ট এবং ইয়ে আছে তাদের জন্য বেশ প্রায় কিন্তু এগুলো আমাদের খুব খুব ক্লিন কাট দরকার। যেমন খুব ইউজ হয় ওল্ড এমআই, রিসেন্ট এমআই, আইসিএম, এই টার্মগুলো একদিন যদি হাফিজ এই বেসিক জিনিসগুলো একটু কভার করে তাহলে খুবই লাভবান হবে। তবে আজকের লেকচারটা রিয়েলি খুবই এক্সেলেন্ট এবং আউটস্ট্যান্ডিং ছিল এবং প্র্যাকটিক্যাল। আমি নিজেও যে জিনিসগুলো ফেস করি আজকে অনেকগুলো জিনিস শিখলাম যে আমি কি করি এবং হাফিজ ভাই কি বলছে। রিয়েলি এটা খুবই প্র্যাকটিক্যাল জিনিস ছিল আজকে। তো
It was a collective discussion.
জি 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 রাইট, আসলে তাই।
স্যার আমি অপেক্ষা করতেছিলাম শোনার
আমি
জন্য
যে
অনেকদিন।
কেসগুলো প্রতিদিনই ফেস করি আজকে হাফিজ ভাই কিন্তু সেরকম কেসই দেখাইছে, এবং আমি চিন্তা করলাম যে আমি কি করি আর কি করতাম। রিয়েলি এটা থ্যাংক ইউ ভেরি মাচ, খুবই একটা বিউটিফুল লেকচার শুনলাম। আর আমাদের নেক্সট মান্থে আমাদের লেকচার আমি রিকোয়েস্ট করবো রফিক স্যারকে, স্যার নেক্সট মান্থের লেকচারটা আপনি পারবেন স্যার?
স্যার আনমিউট করতে হবে।
What date?
স্যার
এটা
24শে আগস্ট রোববার।
Sure.
জি স্যার, জি স্যার। তাহলে
স্যার আমরা স্যার একটু আপনার কাছ থেকে স্যার সেই কন্ডাকশন অ্যাবনর্মালিটি এন্ড ইসিজি কোরিলেশন which is
Sure.
এটা স্যার খুব ভাইটাল একটা জিনিস আমার কাছে মনে হয়।
Okay, we'll do that.
ওকে থ্যাংক ইউ স্যার।
তো ঠিক আছে, আমার মনে হয় যে আমরা আজকে কনক্লুড করতে পারি। ওয়াদুদ ভাই
আতার ভাই, আমাদের যে একটা প্রোগ্রাম করতে যাচ্ছি সেটা কথা একটু জানিয়ে দেন।
জি স্যার।
স্যার আমরা যে মানে আমাদের এটা তো হচ্ছে স্যার, আমরা ইন পার্সন একটা প্রোগ্রাম করতে যাচ্ছি স্যার আমাদের এনাম মেডিকেল কলেজে
12 তারিখে।
12 তারিখে।
12
আমরা
তারিখে
আগস্টের 12 তারিখে স্যার। হ্যালো,
Sure.
তো
স্যার
আমরা
এটা মূলত মেডিকেল কলেজের স্টুডেন্ট এবং ওখানে ট্রেনি ডক্টর তাদেরকে টার্গেট করে ফোকাস করে করা আর কি।
তো এটা তো তোমরা করো, কারণ এটা হয় কি যদি অডিও ভিজুয়াল ঠিক না থাকে দূর থেকে জয়েন করা ইজ টাফ, রাইট?
দিস তা আমরা দেখবো স্যার। আমরা মানে
অডিও ভিজুয়াল ভালো থাকে, I will be happy.
ঠিক আছে স্যার, তো ঠিক আছে ওয়াদুদ ভাই, তাহলে থ্যাংক ইউ ভেরি মাচ স্যার। তাহলে আজকে আমরা এখানে শেষ করতে পারি স্যার।
ওকে, শেষ করি। বাই।
থ্যাংক ইউ স্যার, বাই।
থ্যাংক ইউ স্যার। আসসালামু আলাইকুম।